Next up, we have outcomes of a single-center experience in eliminating routine postoperative duplex ultrasound following endovascular endovenous ablation, presented by Eric Woodhouse.
Good morning. Thank you for that introduction, and thank you to the Society for giving us time to present our work this morning. Neither myself or my colleague, Dr. Paul DeMusto, have any disclosures to make pertaining to our research. The 2021 Joint Society for Vascular Surgery and American Venous Forum guidelines recommend performing a duplex ultrasound 48 to 72 hours post-ablation, and that's to rule out a thrombotic complication. And this is a 2C recommendation that's based on weak evidence. In September of last year, our vascular surgery group decided to stop performing routine ultrasounds on our ablation patients. And this decision was made after we, on our own, analyzed the body of research on endovenous ablation and EHIT, and we ultimately found that there was insufficient evidence to support universal ultrasound screening for all of our patients. We further felt that by doing an ultrasound on every patient, that this could potentially create more harm than good for our patients. And we found this to be a potentially wasteful and not cost-effective practice for the prevention of VTE complications in our patients. Then we further felt that this may improve access to our vascular lab for new patients. And last, we believe that this research would be important as it would be the first study to examine outcomes among patients who did not have ultrasound performed after ablation. So the aim of our study was to describe outcomes among patients who did and did not have ultrasound performed. And secondarily, we examined the cost savings by limiting routine ultrasound. This was a single-center prospective cohort study of consecutive patients undergoing ablation at our institution between September 30th and March 15th of 2022. All patients were seen in clinic for a one-week routine postoperative visit and suture removal. All patients who had an ultrasound performed had one done within 72 hours of their procedure. And the reason why some of our patients did have ultrasound and some didn't was twofold. First, as a group, we felt that a prior history of DVT or PE would increase the risk for development of EHIT. And secondarily, in a large organization, it was difficult to make a practice-wide decision overnight. And so some of our earlier patients ended up having ultrasounds ordered. And then at 30 days post-ablation, we reviewed medical records for each patient to determine if any had been seen or evaluated for venous thromboembolism symptomology. And we further used our Care Everywhere platform tool to evaluate to see if any of these patients were seen at any other facilities other than our own within that 30-day time period. So we had a total of 76 patients in our series. We had 30 male patients, and 5 of these patients had a prior history of DVT or PE. And the male median age was 53. We had 46 female patients. 4 of these patients underwent bilateral endovenous ablation during the same procedure, and the median age amongst our female patients was 55. So of a combined total 80 procedures, we did 71 endovenous laser and 9 radiofrequency ablation. And of these patients, 68 also had avulsion phlebectomy, 7 had anterior saphenous vein ablation, 8 had incompetent perforator vein ablation, and 7 also underwent sclerotherapy. So of our 80 procedures, 54 patients did not have an ultrasound performed, and none of these patients were found to have VTE symptoms at 30 days post-procedure. Of our 24 patients who did have an ultrasound performed, there was no EHIT identified on their 72-hour ultrasound, and none of these patients were found to have VT symptoms at 30 days post-procedure. And we met with our finance colleagues frequently who helped us do a thorough cost analysis based on stopping universal ultrasound. And we determined that within our organization, the combined cost for performing this study was $265 per patient. And when we multiply that by the 54 patients that we did not get an ultrasound on, we estimated a cost savings of a little over $14,000. Importantly, in our analysis, we were found to have a positive opportunity cost for our organization. And so by eliminating this practice, we were able to open those time slots for new patients who needed vascular imaging performed. And this did improve access to our vascular lab, though it was hard to quantify. So it's in our opinion that the strongest driving assumption for performing the post-ablation ultrasound is that you can identify EHIT, treat it, and prevent PE or death in your patients. There's no evidence or there's no objective evidence to support this assumption, and the guidelines clearly acknowledge this as well. If postoperative ultrasound is being used as a clinical screening tool, then we need to temper the underlying assumptions of a screening tool. And those conditions are that the condition has serious consequences, treatment of the asymptomatic patient is better than in the symptomatic patient, and the prevalence of the condition is moderately high. From over 15 years of EHIT data, what we can confidently say is that we cannot unequivocally state that EHIT2 has serious consequences. There's no evidence to support that treating the asymptomatic patient is better. And overall, the prevalence of EHIT is rare. This is a conservative estimate, but if we're performing 350,000 venous ablation cases annually, and the Medicare baseline reimbursement is $116 per study, then we can conservatively say that we're spending over $40 million annually to screen for a clinical entity with low incidence, presumed benign clinical nature, uncertain clinical significance, and a high diagnostic and treatment cost. The most comprehensive study on the economic impact of post-ablation was performed by Dr. Luis Suarez and his colleagues in Boston, who determined that they would have to perform 2,500 ultrasound studies to identify one EHIT patient at a cost of over $12,000 per study. In 2014, Jones and Kabinec posited that the true incidence of PE secondary to ablation was 0.01%, and that they would have to perform 10,000 ultrasounds to capture one of these patients. The limitations of our research were that this was a retrospective chart review. We had a small sample size, and this was performed within a single institution. In our own experience, by eliminating routine ultrasound, had no impact on clinical outcomes for our patients. It reduced the quantity of return to clinic visits for our patients, improved our vascular lab access, and overall had a positive financial impact on our organization. Routine ultrasound comes with associated healthcare costs and has a low yield given the incidence of clinically significant EHIT is rare. And by clinically significant, I mean a true EHIT 3 or 4. And limiting ultrasound to patients who have symptoms of VTE symptomology can be a cost-effective approach that limits unnecessary imaging, time, and resources with no potential change in clinical outcomes. We agree with several other authors that the role of ultrasound in post-ablation patients is unclear and needs further research, and this may be best answered by RCT among patients who do and do not have post-operative ultrasound performed. Thank you.
One quick anecdotal thing is we've noticed in our lab very similar issues. We used to do ours at a month out and had very, very, very low incidence of EHIT. Pressures in the institution changed our policy to do it at 2 weeks, and now that has generated, discovery of some type 1 EHITs and follow-up visits, increased ultrasound, increased angst to the patient for something that we do nothing about. So I support this paper, and we'll look at our own institution data as well. I think it'll be helpful to build a little consensus on it. We have time for just one quick. Sorry.
Thank you very much for an interesting presentation. So there is a nice systematic review published last month in GVSVL with basically the same conclusions. I just have a quick question. Do you use pharmacological prophylaxis routinely in patients with thermal ablation? And if you do, what's your incidence of DVT and EHIT in your cohort? Thank you.
So we don't use chemical pharmacoprophylaxis. And again, in our series, we had 0 0 incidents of E-hit found. I mean, the next step, I think, is we need to go back retroactively and look at the past few years of data and identify if any of those patients truly had E-hits, but in this series, none did. Thank you for your question.